Hello, welcome to my presentation for my capstone, the disparities and barriers to diagnosis and treatment of autism spectrum disorders and implications for speech language pathologists. I'm going to go ahead and share my screen and we will get started. The purpose of this presentation is to explore the disparities and barriers to the diagnosis and treatment of autism spectrum disorders and, of course, implications for speech language pathologists. The reason why I chose this topic is to develop a better understanding of the topic and grow in my confidence in my advocacy skills and gather more resources to support my future clients. During this presentation, I will discuss autism, the prevalence, the diagnostic process and team, structural and systemic barriers, cultural differences, the experiences of autistic individuals and their families, and potential solutions and considerations for speech language pathologists. A disclaimer before I get started is on the use of language within the presentation. There are two different ways to refer to individuals with a diagnosis of autism spectrum disorder. There's person first language, which is saying person with autism, and there's identity first language, which is saying autistic person. Person first language was created to put the person before the label and separate the person from their autism. Identity first language was created to empower autistic individuals and show value in their identity and really take that autistic term back. There is not a general consensus currently on what the preferred terminology is. However, the autistic community overall prefers identity first language, but preferences do vary by individual person. Throughout this presentation, I will be using both, but I will primarily use identity first language. What is autism spectrum disorder? So the DSM-5, this is the medical diagnosis criteria, defines autism as persistent deficits in social communication and social interaction across multiple contexts and restrictive repetitive patterns of behavior, interests, and activities. These characteristics must be present during early development, and they must cause clinically significant impairments that are not better explained by a global delay or an intellectual disability or another diagnosis. Co-occurring conditions. 95% of autistic individuals have co-occurring conditions. These conditions can be neurological, such as seizures, gastrointestinal, such as feeding disorders, diarrhea, constipation, sleep disorders, and mental health conditions such as depression, anxiety, obsessive compulsive disorder, bipolar disorder, attention deficit hyperactivity disorder, post-traumatic stress disorder, etc. Autistic individuals have frequent healthcare visits due to their needs and frequent emergency services more than non-autistic people do. However, their experiences are overall dissatisfactory. What does the diagnostic process look like? So, concerns or characteristics can be noticed typically around 12 to 14 months of age, and autism can be reliably diagnosed at around 2 years of age. The process is very lengthy, and this causes a great deal of stress for parents. On average, there's about 3 years between initial concerns and diagnosis, but the gap can be anywhere from 12 to 55 months. Many families additionally see 3 to 5 professionals before they obtain a diagnosis. Who is in the diagnostic team? There are differences depending on the setting that you're in, whether it's educational or medical, but different team members can include parents, primary care providers, psychologists, occupational therapists, speech language pathologists, developmental pediatricians, and special education teachers. Services that can be provided once a diagnosis has occurred include speech therapy, occupational therapy, behavioral therapy, cognitive therapy, and feeding therapy, to name a few. To qualify to be an SLP, there are a lot of things that need to happen first. All speech language pathologists need to obtain a master's degree from an accredited university. This would be accredited by the Council on Academic Accreditation in Audiology and Speech Language Pathology. All SLPs also need to complete continuing education and continue to develop their skills and remain up to date on evidence-based practices and contemporary issues. Some of this continuing education may be related to counseling, interdisciplinary collaboration, further training on autism, gestalt language processing, sensory training, and diversity, equity, inclusion training. To practice in an educational setting, SLPs need to obtain their license from the State Department of Education. Not all school districts require that SLPs obtain their Cs. However, many do. And additionally, medical setting SLPs need to obtain their Cs. Most places do require this. SLPs practicing in a medical setting need to obtain their license from the Department of Health from their state and obtain their Cs, which is their Certificate of Clinical Competency in Speech Language Pathology from the American Speech Language Hearing Association. From here, that will be referred to as ASHA. Before obtaining their Cs, SLPs must complete a clinical fellowship year, pass the practice exam, and have a clinical fellowship supervisor and the university from which they obtain their master's degree sign off that they met all the requirements and competencies to demonstrate that they can obtain their Cs. From there, the application is sent to ASHA and they review it and send it back. The clinical fellowship year typically is at least 9 months of full-time practicing. So I mentioned a little bit about educational settings versus medical settings. Earlier, I talked about the diagnostic criteria in medical settings, and now I will talk about what this looks like in an educational setting. While these criteria are very similar, there is a key difference between educational and medical settings. And the key difference in education is that the characteristics need to have an impact on educational performance in order to qualify in the schools. So the Minnesota Department of Education will look at their guidelines, look at the social interaction impairment, the communication impairment, and the restrictive, repetitive, or stereotypes patterns of behavior, interests, and activities, similar to the medical DSM-5 criteria. In the school evaluation report, they will look at the students' academic present levels, their educational needs, at least 2 different observations on 2 different settings, typically by 2 different professionals. This could be by a school psychologist, a special education teacher, speech language pathologist, etc. And a summary of developmental history and behavior patterns, typically gathered through a structured interview with the parent or primary caregiver. Additionally, the evaluation process would include some intellectual testing as well to test for the individual's IQ. Here is an outline of what the different areas look for and what qualifies as an impairment in social interaction. An example would be limited joint attention, difficulty relating to others, inability to keep friends. Communication impairment would look like not using their finger to point a request, lack of imitation, absence or delay of spoken language, limited understanding of nonverbal and even verbal forms of speech. And then the restrictive repetitive behaviors looks like insistence on routines, distress when asked to change the routine, repetitive motions, and potential over or under reaction to sensory stimuli. There are more guidelines here that you can see, but those are just the ones that I would like to highlight today. Again, I mentioned briefly that the purpose of services in educational versus medical models is different. In the schools, the Individual with Disabilities Education Act Formerly, the Education for All Handicapped Children's Act says that schools must provide a free and appropriate public education for all students, and that students should be in their least restrictive environment. That means if students are able to be in the general education classroom for the majority of the day, that's where they should be, and they should be pulled out for additional services as little as possible. They need to be in an environment that is least restricting to them and most conducive to their learning. Again, the purpose of school-based services is to support their education and looks at how their disability impacts their education and how, as professionals, we can support that. In outpatient settings, the services are broader and they focus on maximizing functioning in a range of environments, including the home. So medical models, outpatient services are not only limited to education, but they look at all areas of impact and development. The prevalence of autism. How often is it occurring? Most recent data is changing, of course, but the data that I have here today is that the current prevalence is 1 in 36 children. Autism occurs in all racial and ethnic groups, and it is 4 times more commonly diagnosed in boys than in girls. Over a third of children with autism also had an intellectual disability. These individuals that had both autism and an intellectual disability were often diagnosed earlier than individuals who did not have an intellectual disability. Approximately 1 in 6 children, or 17% of children ages 3 to 17, have a developmental disability. This can be including but not limited to autism, ADHD, cerebral palsy, blindness, and others. Here's a chart showing the prevalence across races and ethnicities. For the first time in recent years, the data has found that the percentage of 8-year-old children that have an autism diagnosis was higher among Black, Indigenous, people of color, BIPOC, compared to white children. So looking at the column on the left, we have Asian and Pacific Islanders with a prevalence of 33.4 per 1,000 children. Hispanic rate is 31.6 per 1,000 children. Black is 29.3 per 1,000 children, and white is 24.3 per 1,000 children. So from the highest being Asian and Pacific Islanders to the lowest being white, that is a range of approximately almost 10 per 1,000 children. So that is a 1% difference if you're looking at that number, I believe. I'm not a mathematician, so don't quote me on that. But there is a different difference in prevalence. However, it is fairly even across the board, all things considered. There are lots of barriers that impact access to services and diagnostic processes. So some systemic and structural barriers are listed here. The first one I would like to discuss is financial barriers. So the time and the cost required with appointments. Oftentimes, the diagnostic process is long, the appointments are long, and they take place over many sessions. I mentioned previously that families often see 3 to 5 providers before they are given that diagnosis. So that is a lot of appointments to go to. This can be financially spending and time consuming. It takes time out of their day to go to these appointments. Families take time out of their day to go to these appointments, and they also have to coordinate things like transportation, childcare for other services, childcare while they're taking their child to services, coordinating with the other services that they may be evaluated for or receiving. There are a lot of considerations and impacts there that present difficulties. Families of children with neurodisabilities face persistent poverty. Autism-related care is expensive, not just in dollars and time, as I said. Therefore, many mothers reduce their work hours or leave work in order to provide care for their autistic children. This therefore worsens long-term financial stability, and these burdens fall hardest on younger, less educated, and minority families. The next barrier I'd like to discuss is lack of health equity. Health equity is when everyone has the same opportunity for full access to health care. Black Americans experience worse health outcomes regardless of income or education levels. Historical and structural inequities like redlining continue to restrict access. Previous acts of redlining causing people to quite literally not have access to services is still impacting us as a society today. Health disparities go beyond money. Systemic racism affects access and outcomes even for higher income families of color. True health equity means removing these systemic disadvantages. This is something that may not be fixed, or these disadvantages may not be removed for a long time, but it is certainly something that we need to be aware of. The next barrier is limited access to resources, education, and quality health care. Families have limited access to resources in multiple languages. So if they do not speak or read English, or if they are illiterate, many times they cannot read the information that is being presented to them in different pamphlets or on social media or in their mail. Sometimes this information may be translated to other languages, but oftentimes it is not. So this is a barrier to information regarding services as well. Families with higher maternal education are able to access services earlier. In the US, there's a direct relationship between autism diagnosis and socioeconomic status. So that means they're both going up at the same rate and they directly impact one another. In other countries such as Denmark or Sweden, there is no relationship between autism diagnosis and socioeconomic status, and there may even be an inverse effect. This may be because countries such as these that have universal health care provide easier access to services. Because in the US we do not have universal health care, this puts a financial barrier in place as individuals who are not on insurance or who private pay may have different guidelines that they have to go by based on what qualifies their child for services and support and how much they have to pay in order to access those services. The final bullet point on this slide is extensive wait lists. Diagnostic wait lists are long. That means people who have the financial means and the connections are able to bypass them. However, those who are without do not. Many families don't know where to go for help, or they don't speak the language of service systems. Therefore, even basic access is often dictated by education, English fluency, and privilege. Additionally, COVID has made impacts on these wait lists that we are not fully seeing the full ramifications of, with a halt in services in 2020 and a halt in evaluations for an extended period of time. This just pushed the whole wait list even longer. So, like I said, it may take up to 55 months for children to get a diagnosis from the point when the parent first brings concerns to their pediatrician. Moving on to the next page of barriers. The next barrier is lack of interpreters or poorly trained interpreters. A lack of interpreters is a huge barrier. This means that we cannot provide adequate services to individuals if we are not speaking the same language. What I mean when I say poorly trained interpreters is interpreters who are merely translating the language and not interpreting the cultural aspects that are also incorporated in the conversation and that are deeply rooted and embedded in our language. The next bullet point is lack of culturally responsive, diverse, and high quality providers. There are very few culturally diverse professionals. For example, only 2% of developmental behavioral pediatricians are Black. Black and Latinx parents often receive less information at appointments with their primary care provider, and they feel overpowered in appointments where the doctor is simply talking at them and not giving them a chance to speak or share their concerns or really listen to them. Clinicians may rely on their subjective judgment and tell families to wait and see and wait for the children to grow out of their concerns rather than providing early intervention like they would if the parents coming to them were white. Families of color often feel dismissed or disrespected by providers. Due to the representation gap in the field, this may impact the trust and cultural understanding and outcomes that occur from relationships between parents and providers. The next barrier is lack of research. The ADOS is one of the gold standard tools when it comes to diagnosing autism, and yet this tool is not culturally validated. I believe it is translated into other languages. However, again, similar to the barrier with poorly trained interpreters, just because it is translated into a language does not mean it is accounting for the cultural aspects that play a role in diagnosis and characteristics. The MCHAT-RF has higher false positives for Black children. Some diagnostic tools go as far as excluding diverse populations during the validation process. Diagnostic tools are often normed on white, middle-class populations, which leads to over or under identification in communities of color and creates barriers to accurate diagnosis. In different diagnostic tools, there were some specific questions that yielded inaccurate results, and those questions were based on about unusual eye contact, stereotyped or idiosyncratic use of words or phrases, and immediate echolalia. These may all be influenced by culture. And finally, the last barrier I'm going to discuss on this slide is intersectionality. This means when two different minority aspects of one's identity come together and create further barriers for the individual. The following quotes are from Pearson et al. From 2019. They say, when race and disability are combined, it is the access of one oppression with another. Race and disability are both social constructs and aspects of one's social identity. We're looking at critical disability theory. This proposes that the social disadvantages that people with disabilities experience are not caused by the disability itself, but rather by the institution and the attitudinal environment that fails to meet the needs of the disabled person. Next, I'm going to discuss disparities in diagnosis. Data shows us that white children are more likely to receive early ASD diagnoses than Black or Latinx children. Black children additionally experience an average diagnostic delay of 1.5 years and are twice as likely to be misdiagnosed prior to receiving their accurate diagnosis of ASD. Some of these diagnoses that they may receive instead of being diagnosed with autism include adjustment disorder, conduct disorder, and an intellectual disability. Adjustment disorder is a trauma and stress-related disorder in which the child experiences depression, anxiety, and exhibits behaviors typically due to a specific event, trauma, or change. And conduct disorder is a behavior disorder in which the child demonstrates aggressive and violent behaviors that violate social norms. On one hand, I can understand why some clinicians may see some of these behaviors and interpret it as an adjustment or a conduct disorder. However, there are three pillars to autism diagnosis, and behavior is only one of them. Social impact and communication are the others. And so it just shows the bias that is present in that diagnosis to not consider communication during that process. Even though parental concern across racial groups emerges at the same time, the identification and access to treatment remain unequal. Black children are also 3 times more likely to be diagnosed after the age of 3, which then closes that window for early intervention. Autistic females often go undiagnosed or are diagnosed later than males, especially when symptoms are less severe or when they have stronger cognitive skills. This is partly because the diagnostic tools are largely based on studies of boys and male populations, and girls tend to mask or compensate socially, which can mislead clinicians or educators. So as a result, many girls or women don't get identified until adolescence or adulthood and miss out on those early supports. Next, I'm going to discuss an article by Golson et al. From 2022. This article shows that disparities stem from implicit bias, cultural misunderstandings, and systemic racism. In this study, they created a case study for school psychologists, and it showed that their diagnostic decisions were influenced by race, gender, and speech language issues were undervalued. They created a case study of a hypothetical second grade student with behavioral concerns, academic difficulties, socialization difficulties, and restrictive repetitive behaviors. They created 8 versions of this case, varying only by sex. They had 4 male and 4 female, and race or ethnicity. So they had Black, white, Latinx, and Asian, male and female. They presented these case studies to school psychologists to examine how they would diagnose the student, what aspects of the case were most pivotal in their diagnosis, and how confident they were in their diagnosis. Overall, the school psychologists ranked the following themes as most to least important. They rated classroom behavior at the very top of the list here, and then it zigzags all the way down to the bottom. The very last one was speech language difficulties. Some more important things that I would like to draw your attention to are the top 3 behaviors: classroom behavior problems, restrictive repetitive behaviors, interests, and activities, and social communication and interaction. The restrictive repetitive behaviors and the social communication are 2 of the pillars of autism spectrum disorder diagnosis. However, communication difficulties is the other one, and it is at the bottom of the list. Additionally, the second lowest one would be strengths-based interpretation and cultural considerations. These, along with the speech language difficulties, were at the bottom of the list, and that is very concerning as a clinician. This study found that speech language difficulties made up only 1% of all codes used during this study. They found that the students' race and ethnicity impact the eligibility decisions, because school psychologists were more likely to and more confident in their diagnosis for as a student with autism for Asian females in comparison with Latinx females, which aligns with previous studies done that Asian students are overdiagnosed and Latinx were underdiagnosed. And this also aligns with the current prevalence that we spoke about earlier. The study found that participants did not mention gender considerations, and some made assumptions about student language based on the race or ethnicity provided in the case study. It is important to note that school psychologists rank speech language at the very bottom of the list, although it is a huge pillar in autism diagnosis, which shows the need for further training and multidisciplinary collaboration required throughout the diagnostic process. There are disparities in service delivery as well. Once a child is diagnosed, access to services isn't equal. White children are more likely to receive intensive outpatient services, while Black and Asian children rely more on school services and do not receive as many outpatient services. Latinx and Native American children show mixed or minimal differences in service access. Studies show that Black children are about 5% less likely to use outpatient services and 5% more likely to use school-based services. One hypothesis for this and reason for disparity is that school services are much more accessible. They are free and they do not require parents to go out of their way for transportation or coordinate additional activities on top of their day. Additionally, the minimum requirement for parents is one IEP meeting a year, and IEP is the Individualized Education Program. And that is the legal binding document that shows the supports that the student needs and the services that they will be provided. This plan is updated yearly, and every 3 years is a new evaluation. So the schools are far more accessible than outpatient for parents who have a lot more going on at home and who have a lot more barriers in their way. Some more reasons why these disparities exist. Autism presents differently for males and females, and also it is important to consider that there is a difference in the purpose of the service delivery model for schools and outpatient. The reason that students can get services through the schools is because their disability has an impact on their education. Some individuals may be autistic and they may be able to receive outpatient services or have difficulties in their daily life, but do not receive school services because their disability does not have an educational impact. Also, individuals may qualify under a different diagnosis. Earlier, I talked about the overlap between intellectual disability and autism, so they may be qualified under that category. Again, individuals with less needs may not qualify if it does not impact their education. Students who are misdiagnosed or undiagnosed may receive inappropriate interventions and delay necessary supports. For example, if a child that is autistic is misdiagnosed with a conduct disorder, they may be receiving services for behavior management and being pulled out of the classroom for behavior services, but miss out on the underlying need for communication support, which is why they are exhibiting these behaviors to begin with. This just further perpetuates difficulties, and the gap in achievement gets greater and greater. Black children with lower severity autism characteristics are less likely to be identified, which limits access to early intervention, and these individuals may fall through the cracks. Intervention effectiveness by demographic. Overall, we know that there's an underrepresentation in research. This could be due to a variety of things. One reason for that is that individuals from diverse backgrounds have a distrust of researchers and healthcare professionals. Historically, there's a lot of abuse involved in research, and those practices have gotten much better today with the review board making sure that the research that's being conducted is ethical and safe and beneficial for the participants. Additionally, there's a time commitment that's involved with participating in research, and individuals may have to take time out of their week, coordinate other childcare, coordinate transportation in order to go someplace to participate in research, or they may need to use a computer or device at home with internet access that they may not have access to. That would be another barrier to participating in research. And finally, sometimes the research may appear to be irrelevant to the participants. They may think there is no immediate benefit from this and misunderstand the long-term benefits of participating in research. The scope may not be relevant to what they're experiencing currently. Beyond the participant-related concerns with participating in research, there are a lot more reasons why individuals from diverse backgrounds are underrepresented in research. We know that clinicians are more confident in diagnosing white individuals compared to BIPOC individuals, that there is implicit bias in diagnosis and treatment. We know that disparities exist due to race and ethnicity despite the socioeconomic status. And okay, sometimes there are barriers that prevent individuals from participating, such as inclusion criteria is not culturally sensitive. Some more information on intervention effectiveness. A study by Pope et al. In 2022 found that Black children receive less AAC intervention in the school settings compared to their white peers. They found that 75% of Black students received less than an hour of AAC intervention per week, and only 28% of white students received less than an hour of AAC intervention per week. They measured this intervention across school settings, not just in the speech room with the speech therapist, but also in the classroom with paraprofessionals. They measured this as any time that the child or student was spent with their AAC device with an adult. And 75% of Black students had their device less than an hour a week. Black children with complex communication needs are at a higher risk for having barriers that persist into adulthood. Unmet communication needs can cause have on be the underlying cause, which then leads to behavior problems. If the student is acting out and having behavior problems, they may be removed from the classroom and losing access to their education. And this just persists and the gap gets bigger and they struggle more and more over time. This leads to further communication challenges and the cycle of inequity. And these disparities continue into adulthood. Black and Hispanic transition age youth with developmental delays have worse outcomes after high school compared to white peers with developmental delays. They have lower rates of employment, lack of independence, less post-secondary enrollment, less social participation, and lack of access to healthcare. This all perpetuates the cycle of poverty. And finally, research and evidence-based practice may not always relate to individuals from diverse backgrounds because it is normed on white individuals. Contextual factors are not always accounted for, such as the family, culture, background, and their native language, and many studies simply do not gather information from their participants about race or ethnicity or nationality data, and they may have barriers within participant inclusion, such as English proficiency or two-parent homes as qualifiers for participation. There are many differences in cultures that are important to note. There's differences in cultural beliefs and differences in cultural behaviors. Some cultural beliefs that may differ. Some families may have a great fear of the stigma and discrimination that comes with having a child with a disability diagnosis. Some cultures may believe that the diagnosis is a divine punishment and carry more shame regarding that and feel as though they are to blame for their child's diagnosis. Many cultures, as I previously stated, may be distrusting of systems and of researchers and healthcare providers, and and again view their child's disability as punishment and rely on their extended family and their community to provide support. Different cultures have different expectations and views on the role of teachers, parents, and providers. They may not want to reach out for support because they believe that that is the parent's job and just simply rely on their extended family and be very apprehensive towards receiving services. There is a difference in cultural behaviors, which impacts assessment because assessment looks at nonverbal behaviors and adherence to social norms, both of which vary across cultures. In Asian cultures, eye contact can be a sign of disrespect. Children are not to look adults in the eye. That can be seen as disrespectful. So, a diagnostic professional may be working with an Asian child and notice that they are not making eye contact. And they may write that off as being a characteristic of autism. However, that may not be the case. That may be a cultural difference. This is why having a comprehensive assessment and interview with the parents to and use of quality interpreters to better understand the cultural aspects of the client and their family and their community is essential. Different cultures may also notice different characteristics of autism first. For example, in Indian culture, they may notice characteristics such as social difficulties earlier compared with Western cultures, which may notice global delays or expressive language delays first. Additionally, white children are more likely to demonstrate inflexible adherence to non-functional routines and persistent preoccupations with parts of objects compared to Black children. So that's a difference in behavior as well. Some cultures are more high context and they use more indirect or implicit messages, and some are low context and emphasize verbal messages. This may impact nonverbal behavior as well. Bilingual children may have unique patterns as they are exposed to multiple cultures and may be mixing them together. Um, More research supports that culture impacts developmental milestones and how children play with different toys, how they show emotion during play, and how they engage in pretend play. Play is a pivotal part of the assessment process, and being aware of this is essential to be able to provide appropriate assessment. Family perspectives. Parental beliefs on the cause of autism vary across cultures and socioeconomic status. Some cultures, like I said, believe that it is a punishment due to parental actions. Research shows that low socioeconomic status parents are more likely to believe that autism is caused by in utero or postnatal exposure, whereas parents from higher socioeconomic status and higher education are more likely to believe the cause of autism is genetic. This shows that individuals from low socioeconomic backgrounds may have limited knowledge, and it may be due to limited access to or experience with healthcare providers that can explain the reasoning in a way that they understand. Many parents also go through the stages of grief when they receive a disability diagnosis for their child. They are grieving the idea that they had and the expectation that they had for what their life as a parent would look like and what their life for their child would look like. This is common and may show up in different ways. They may fear what their child's life will look like and the hardships that their child may face because they're autistic. Parental stress is often higher in families with autistic children. This may be due to the increased needs of the children and the reduced work hours in families, creating more financial stress. Additionally, changes in routine, coordinating treatment, increased finances, children's behaviors, disruption of daily routines, child's irregular sleep patterns, communication difficulties, restricted behaviors in eating, and just overall high needs are all some factors that may contribute to higher levels of stress. Additionally, it may be extra difficult for parents to parent children when they have an autistic and a non-autistic or a higher need and a less high need child in the home, and trying to split that attention between those two children can add stress to the whole family system. Additionally, parents may be trying to implement therapy at home and while also navigating social stigmas that they may face and navigating the grief and going through those stages of grief again. Perhaps one of the most important parts of my presentation is discussing the lived autistic experiences. So the first thing I would like to discuss is the double empathy problem. So this is when individuals that are autistic and individuals that are not autistic are having conversations together and communication breakdowns occur. Typically, excuse me, society is quick to blame the autistic person to be the cause of the problem and say that they need to learn how to better communicate, they need to learn theory of mind, and they need to communicate better. When really, communication breakdowns are bidirectional. It is a mutual lack of understanding between the groups, and it is not all to put on autistic people. Autistic individuals do not lack theory of mind. They oftentimes communicate differently. Oftentimes, these communication breakdowns only occur when the two groups overlap. When autistic individuals communicate with other autistic individuals, communication breakdowns are far fewer. And same with when non-autistic individuals communicate with other non-autistic individuals, the communication breakdowns are less. These breakdowns are heightened when the two groups go together, and that just shows that the breakdowns are bidirectional. Intersectionality and the double minority effect. There is limited research on queer autistic individuals, despite the fact that autistic individuals are more likely to be queer than allistic or non-autistic individuals. This data is between 40 and 60% of autistic adults are queer. It is a common misconception that autistic individuals are not able to connect with others or show affection in a way that non-autistic individuals can, and this is false. Research has discovered that the double minority effect plays a huge role on autistic individuals. The double minority effect is the psychological state that is created when two devalued identities interact, or intersectionality, to influence the individual in a way that is greater than the sum of the independent effects of those identities. The double minority status has been linked with higher mental distress, poorer well-being, and minorities that experience chronic stress from prejudice and discrimination are at greater risk of physical health problems due to experiencing chronic stress. The next topic I'd like to discuss is law enforcement encounters. Black autistic men are at a higher rate of discrimination and potential violence when encountering law enforcement officers. Many law enforcement officers lack adequate training in recognizing characteristics of autism, and they may misinterpret certain behaviors and actions, such as avoidance of eye contact, difficulty with communication, repetitive behaviors, not necessarily listening and following directions immediately. They may interpret that as suspicious or threatening or lacking compliance when that may not be the case. These encounters between law enforcement officers and autistic individuals have resulted in excessive use of force, psychological and physiological harm, and even death in some instances. Research report that by 21 years of age, 20% of autistic individuals have engaged with law enforcement officers and 5% resulted in an arrest. Another study showed that law enforcement officers responding to calls involving autistic individuals, they stated that 15% used physical force and 25% resulted in involuntary hospitalizations. When considering the core range of characteristics of autism, autistic individuals may have difficulty following commands, especially during a high stress, high pressure situation, and this can elevate the risk of police harm. And going back to that intersectionality, having another minority impact of being Black and being a male is another huge factor to consider in this situation. Black autistic men, young men, are 7 times more likely to encounter law enforcement officers when compared with white men, and young Black men have 3 times the likelihood of being killed by law enforcement officers. This is something that's very important to consider in all settings of treatment when working with autistic clients, and to consider this during our advocacy work as well. The last bullet point on this page is ableism and discrimination. I love this article by Oates and Bean from 2023. They discuss the experience of autistic SLPs, and one of the main takeaways is that autistic SLPs are facing ableism and discrimination in their workplace. Many supervisors and colleagues were often apprehensive and concerned that autistic people could not be SLPs, when quite the opposite is true. Neurodivergent individuals bring a unique perspective to the field and can bring a unique connection with clients and can help advance research and neurodiversity affirming care. We should be working to increase diversity in the field, especially to better understand the lived experiences of the clients and their families that we are serving. This brings us to the ethical considerations. So, how can we, as SLPs and professionals, appropriately assess and treat autistic clients from diverse backgrounds if the assessment materials are not normed on these populations, and if there is lacking evidence in treatment approaches that are culturally and linguistically sensitive? The ASHA Code of Ethics has many principles and rules that support this and help us as professionals. So, the first one is, I'm going to just sort of summarize this information. If you would like to read the ASHA Code of Ethics, is in my citations, my references. So Principle 1, Rule C, states that individuals shall not discriminate in delivery of professional services or conduction of research, no discrimination of any sort. Principle 2, Rule C, says that individuals shall enhance and refine their professional competence and expertise and do continued education and continue to learn and grow in their skills. Principle 4, Rule A, states that individuals should work collaboratively with members of their profession and members of other professions to deliver high-quality care. Principle 4, Rule M, says that individuals should not discriminate in their relationships with colleagues, members of other profession, or individuals under their supervision under any circumstance. And finally, Principle 4, Rule S, states that individuals shall comply with local, state, and federal laws and regulations. This brings us into contemporary professional issues. There, with potential cuts to diversity, equity, and inclusion training and to Medicaid, this has a great impact on the field of speech language pathology. This impacts both medical and school-based services. Medicaid is the largest payer for autism-related healthcare services in both medical and educational settings. Medicaid provides coverage for individuals who are low income, qualify with a disability, and or are in foster care. If national Medicaid funding is cut, this would be up to the states to decide if they are able to pay for coverage to continue to support their clients that receive Medicaid. Should Minnesota choose to take this over, it would cost $14.4 billion per year to take over this cost. Finally, moving into some solutions and what we can do about all of these problems and disparities and barriers. We can support and promote diversity, equity, and cultural humility among researchers and clinicians. We can conduct research that addresses the specific needs and interests of underrepresented populations. We can ensure that we're collecting large, nationally representative samples or samples in which traditionally disenfranchised groups are overrepresented. We can work with community partners and incorporate them into research and have a better understanding of their concerns and their needs. We can reflect on our personal implicit bias and engage in implicit bias training and continued culturally responsive training and education. We can cultivate a diverse research and clinical team by increasing diversity and making education and training more accessible and culturally responsive. We can develop a strong rapport with our families in order to utilize a client family-centered approach and share decision-making with families. We can utilize telehealth services to provide more access, as this is shown to be an effective, acceptable, and usable modality for both evaluation and intervention. This way, individuals do not have to coordinate transportation and they can still access services if they have barriers in their life preventing them from doing so otherwise. We can use various techniques to minimize traumatic experiences for individuals with an autism diagnosis. We can do sensory modifications such as dimming the lights, reducing noise. We can provide total communication approach, such as using a device to communicate, gestures, writing. We can accept all forms of communication. We can use clear communication to explain the procedures and expectations in advance, use visual supports, schedule visits during less busy times that work best for the client, and allow extra time for appointments or assessments. And we can also document and respect their preferences so that when they go see other providers, that information is documented so the providers can be prepared, and this will help establish rapport as well. We know that autistic individuals have negative experiences, especially those from diverse backgrounds with healthcare. So it's very important that we make sensory modifications and are practicing trauma-informed care. It is very important that we listen to minority voices and hear their concerns and respond to those appropriately. Specifically for speech language pathologists, there are some considerations here. One is providing neurodiversity affirming care. Julie Roberts has a website that has tons of resources on what neurodiversity affirming care looks like. One thing that we can do is make sure that we are supporting advocacy, we're not writing goals based on eye contact, and that we are just informing clients of what social norms and expectations are, but do not require adherence to them. We can select assessments with caution. Providers should proceed with caution when choosing a screening or assessment tool and be mindful of cultural differences when assessing. It is also important to place a great importance on parent interview as part of the evaluation process to have a better understanding of their concerns, their values, and their child needs and strengths. Additional assessment considerations would be dynamic assessment, informal assessment, and observations. These are huge and there are things that are extremely beneficial. We can modify assessments if possible. Many children use self-directed, context-specific scripting communications, they may have difficulty demonstrating their abilities during a formal assessment. So using some of these informal and dynamic assessment tools can be a great way, and observation can be a great way to see what their abilities and what their strengths are. Another thing to consider is when assessing autistic children for speech sound disorders, the typical measures such as oral motor examination, connected speech sample, single word speech assessment, and stimulability testing are appropriate and necessary. However, some accommodations may need to be made in order to see what their true abilities are. This may mean taking additional time and spending more time developing rapport prior to administering the assessment, taking more breaks during the assessment, things like that. It is important to consider what the purpose of the assessment is because, for example, if you're administering a speech sound assessment, the purpose of the assessment is not to see if the child or client can attend to the assessment and identify all of the images. The purpose is to hear their sounds and listen to their speech sound production at the single word level. Um, so if modifications are necessary, it should be appropriate and noted in the report. Again, incorporating parent interviews to have a more holistic view on what the family and culture and values is like. Using a disability interpretive lens and a strengths-based approach can help guide clinical decision making. SLPs can work with autistic clients to support their skills by using their strengths to their advantage. This helps establish confidence and independence and continue to develop rapport. It also teaches autistic clients that they don't have to conform to society's standards, but to be aware of what the standards are. This increases the quality of life for these clients and may reduce their risk of having depression, anxiety, and many other negative outcomes. We can support client advocacy and incorporate this into our treatment and goals. Listening to autistic voices, reflecting on our biases, continuing education, and again, taking a client-centered approach to treatment. It's very important to provide an environment for clients and fellow clinicians to feel safe and to feel like they can demask and just be themselves. That's the best way to support neurodiversity affirming care. In conclusion, autism is a neurodevelopmental disability that occurs in all races, ethnicities, sexes, regardless of socioeconomic status. However, prevalence rates and service delivery rates vary due to societal barriers, cultural differences, lack of access and awareness, financial barriers, and bias. Potential solutions include increasing diversity in research, utilizing a client-centered approach, implementing neurodiversity affirming care, and listening to autistic voices. I'm just going to briefly click through my references. Thank you for watching my presentation and listening to me discuss autism and how I can better support my autistic clients. I really enjoyed reading all of these articles and doing this research and hope to continue to do so in my practice as an SLP once I complete grad school.